Hello, my name is Kathy Grand. I'm a health professional working in Calgary, Alberta, and I've been asked to moderate a discussion concerning the crisis in healthcare in Canada and our search for solutions. In Canada, we have come to expect a high level of healthcare almost as an innate right. We're very proud of our system. It is being held in esteem worldwide and has a reputation as being one of the best. The Canada Health Act has established basic principles that guarantee every Canadian reasonable access to a range of medical services regardless of age, location, or ability to pay. More recently, the growing cost of assuring this right to health care has created concern, and this concern has a voice that is growing louder. Articles in newspapers, magazines, and commentaries on radio and television appear almost daily. Statements warn us of the need for rationing of services and control of expensive technologies in light of the current economic situation in Canada. To help us to explore, define, and analyze these issues, we've invited three special guests. Reza Dieber, Jeremiah Hurley, and Tim Sale have examined, pondered, and written about the current situation in healthcare. We will ask them to share their views and perspectives on the state of our health in Canada as we search for solutions to this dilemma. But first, I would like to ask our guests to introduce themselves and to tell you a little bit about how they became involved in healthcare. Reza, would you like to tell us a little bit about yourself?
Well, I was educated in the United States, but then came back. I am a professor of health policy at the University of Toronto. I teach graduate students, people who are going to become hospital administrators, public health doctors and public health professionals, and medical students. And I've done a great deal of teaching, writing, research, and thinking about our healthcare system and how one can preserve it.
Thank you. Jeremy.
Hi, Jeremiah Hurley. I'm an assistant professor at McMaster University in the Center for Health Economics and Policy Analysis, which is an organization dedicated to conducting research on health and healthcare issues. I'm from the United States, and it's actually been particularly interesting for me to come up to Canada about 5 years ago to study the Canadian system. It's been very interesting to both look at the achievements of the system and the challenges that it's facing today. And so I'm very much looking forward to our discussion.
Tim Sale.
Thanks, Kathy. I've worked a lot in the area of kind of popular education around the issues of healthcare. And basically, I come to it partly out of a story that I'd like to share at the beginning of our discussion, because I think you said in your introduction that it's only about 20 years that we've had a full system, and that's true. And yet that 20 years seems like an eternity, and people have a great deal of trouble remembering what it was like before Medicare. But I think that it's important that we remember what it was like so that we can hold on to the priority that Medicare is for everybody. And the little story that I use that's really an important one for me is a simple car accident. My father, like many men coming back from World War II, didn't have a whole lot of skills and had trouble finding a job. Finally found a job in Seaforth, Ontario, which those of you who know Charlie Farquharson know that that's really where Charlie Farquharson is from Seaforth. He was coming home one evening facing the sun, and a farm truck drove out of a field and across the highway just right in front of him, and basically it was a serious accident. Uninsured driver, uninsured vehicle, and no health insurance. He wound up, he was in hospital I guess about 3 months, and he had just started this job. So we had no savings, and basically, had it not been for my grandmother, we would not, I think, have been able to avoid going on welfare, because there was no unsatisfied judgment fund availability at that point within a period. It took years to get through that process. I think it's not an exaggeration to say that I wouldn't have gone on to university. I suspect I would have had to go to work at 16 or 17, because basically I was the only other means of earning money for the family. So for me, Medicare is that kind of security that says that even when a family is in any kind of distress, there's a basic right to not be bankrupted when something serious or something even minor happens. And I think it's important that we hold on to stories like that when we're worrying about the future of our Medicare system.
I think it also raises the question of how much of that kind of care will be always there for us. And I speak as a baby boomer moving along and realizing that there's going to be a large number of us moving into the elder category, and I hate to say it, but the not too distant future. We seem to have a fair amount of choice around caring for our elders today. Will we be able to afford that in the future?
Well, Evelyn's argument is that in the very near future, the baby boomers are going to be you're going to be giving the care to your parents. That the people, the frail elderly now who are needing care, didn't have that many children, so they don't have alternate caregivers. The parents of the baby boomers, presumably, if the children haven't moved away to Toronto, will have available more people to help give care. And that's one of the reasons why, if you look at government programs, under the guise of community-based care, what they're trying to do is shift back responsibility for a great deal of the caregiving back to the family members and children, with the assumption that you and me and all us other baby boomers are going to pick up that load.
But I think that's a real false assumption in the sense that the people who have traditionally been the caregivers in the family at home are no longer there. The women are in the workplace. I hate to tell you, but that's basically where they are now. Who's going to be available then in place of the family members to assume this care? And I personally have a concern about that when it comes to be my time. Who's going to care for me? And can our system, as we have it set now, continue to afford that, or are we going to make some radical change?
I don't think there's any question that there's a crisis, but I think there are a lot of popular misconceptions about what the nature of the crisis is. Very briefly, the crisis has two very broad dimensions and then a whole bunch of sub-dimensions. Broadly, the cutbacks in federal funding to the point where sometime towards the end of this decade there will be no more federal cash transfers for health care means that provinces have to absorb each year a bigger and bigger share of the burden. And all provinces are finding that a problem. Certainly the province of Ontario is, as those who live there know. But those of us who live in the poorer provinces know that it's even more of a burden in the very poorest provinces. So the capacity to have a national system is at risk because of federal funding withdrawals. But on the other side, our whole understanding of what constitutes good health care is becoming more of a critical question too. So we need to look at service delivery areas, what services are in fact going to be covered, and we need to uncover and get back to our understanding that health, public health, really comes from services that are quite outside what we call the health care system. So I think there's a lot of dimensions to the crisis. But you know, the old Chinese ideogram for crisis contains the idea of opportunity. And in this crisis, there are a lot of good opportunities too.
Please stop the tape now. This is the end of the video segment for the first workshop. In the first video segment, we were introduced to panelists Tim Sale, Grace Adieber, Jeremiah Hurley, and the panel moderator, Catherine Grand, who asked questions and told stories to illustrate their concern regarding the state of healthcare in Canada. We rejoin them as they discuss our healthcare system further, including questions such as, is there a crisis in healthcare in Canada? How does the Canadian healthcare work? And what about vested interests of groups in the healthcare industry?
Oh yes, I don't think there's any question that there's a crisis, but I think there are a lot of popular misconceptions about what the nature of the crisis is. Very briefly, the crisis has two very broad dimensions and then a whole bunch of sub-dimensions. Broadly, the cutbacks in federal funding to the point where sometime towards the end of this decade there will be no more federal cash transfers for health care means that provinces have to absorb each year a bigger and bigger share of the burden. And all provinces are finding that a problem. Certainly the province of Ontario is, as those who live there know. But those of us who live in the poorer provinces know that it's even more of a burden in the very poorest provinces. So the capacity to have a national system is at risk because of federal funding withdrawals. But on the other side, our whole understanding of what constitutes good health care is becoming more of a critical question too. So we need to look at service delivery areas, what services are in fact going to be covered, and we need to uncover and get back to our understanding that health, public health, really comes from services that are quite outside what we call the health care system. So I think there's a lot of dimensions to the crisis. But you know, the old Chinese ideogram for crisis contains the idea of opportunity. And in this crisis, there are a lot of good opportunities too.
Do you agree, Reza, that we have a crisis in healthcare in Canada?
Yes, and I also agree with Tim that, to use a medical metaphor, there's been quite a bit of misdiagnosis about what the crisis is. We keep talking about the crisis as though it's a crisis of costs. That's true in part, but the easiest way for anyone to contain costs is to shift them to somebody else. And when I hear the talk about the crisis being because of federal cutbacks, I don't find that a particularly convincing thing. The overall costs will be the same, and the issue becomes who you start shifting them around to. So I think if you define the question about costs, you start coming into questions about, oh, can we shift them here, there, and everywhere else? And the way we're doing it in Canada right now, in international sense, is probably the most effective way of handling the total costs of the system in terms of the amount of national wealth going into health care. I think the broader question is appropriateness, is what we're buying for the money doing the most to maximize health, or are we buying things for the money such as jobs, employment, community prestige, other sorts of things that don't really have a lot to do with the health of the public? And I think I still am totally convinced that it is possible to maintain an absolutely first-rate healthcare system without having to privatize it or anything else if we focus our attention on appropriateness and making sure that what we're doing is what people want and need. But that will involve letting go of some myths that we've been clinging to.
I'll get back to the myths in just a moment, but we'll ask Jeremiah about the crisis in healthcare in Canada.
Yes, I mean, I agree with much of what Tim and Reza have already said, in that I believe, I'm a bit more cautious about using the word crisis. There's certainly some serious problems that our system is facing. And I think, as Tim pointed out, the funding question is an important one. The provinces are facing very difficult times fiscally, and to shift more burden to them is creating problems for those provinces as they struggle to maintain the level of services across programs. I would also, though, agree with Reza that the system has been very successful in many terms, and I think in particular in terms of what it would initially set out to do, providing access to all Canadians to healthcare services. I think after a couple of decades with the system, we're coming to learn that the health of the population of individuals is determined by many things beyond healthcare. And also we're coming to understand the limits of what healthcare can do and the services provided through our system. And so I believe we're going through a period where we're re-examining some basic tenets that we held when we established the system. And I think this is for the good, because we've come to understand our health and our health care much more now than when we set the system up. And so I believe there are some positive developments going on in the system today. And as Reza said, we can preserve the system, I believe, if we have the will to make the choices that need to be made.
I think it is really vital to say that in a federation like Canada, if you don't have national standards, then it's very difficult to talk about the mobility of people, very difficult to talk about how we can call ourselves a nation if our healthcare system is not, in some sense, nationally mandated. Now, we can't do that constitutionally except through the federal spending power. So when the federal government pulls out all of its money, we have then said we're going to have 12 or maybe 13 healthcare systems. Now, I know we do have that now, but it will make it inexorably worse as provinces, because provinces have different political views about whether systems should be fully insured, whether co-payments are appropriate, whether user fees are a good thing. We are going to have a very different system in different parts of the country. And I think different to the point of being worse for some people. Now, you can argue that some of them might turn out to be better than we've got now, and that might be true. but I guess I'm enough of a kind of social justice person that I want to ensure a pretty broad range of guaranteed services and then start talking about
Yeah.
building on the guarantee. So I'm really happy to leave the federal government. Nobody wants to talk about the federal government much these days, but let's agree that they have a role in national standards, and unfortunately or fortunately, the only way that gets exercised in Canada is with dollars.
I agree. But the things that you were talking about, they've never even had a role in those.
Oh,
so
no,
if
no,
you're
no,
talking
wait a minute.
in
No, you're
strengthening-
not. No,
Yeah.
you're misrepresenting what I'm saying.
Okay.
The things that I'm concerned about are portability, affordability, comprehensiveness, universality, and public administration, the 5 pillars of Medicare.
Right.
That's what they guarantee. That's what they have the lever to do. And those are the things that I believe are very much at risk
Yeah.
as we get into states' rights provinces, like Alberta, for example, who are open to bringing in American management, for-profit management of the healthcare system, insurance, co-insurance. I mean, people are open to these ideas
Premiums.
because, in fact, well, they already have premiums.
Yeah.
Because, in fact, the Canadian public is willing to talk about user fees, 60% on surveys. This is a very dangerous road to start trotting down, and we've all agreed on that.
Definitely
So
agree on that.
I think we're going to go off and talk about other things as well, but that one I think is critical. The federal government must stay somewhere in the picture.
I think it might be appropriate now to involve our audience a bit in some of the questions that they may have about some of these issues and that they can address to you as well. Who would like to be first to step to the mic and get involved in the discussion?
First, I think it would be helpful if we understood how the system worked currently. Secondly, does the transfer program interfere with the ability of the province to manage its own affairs? And this is an issue that was a major problem at the constitutional debates.
I guess I would want to say first, the system is relatively simple, but it has lots of complexity underneath it. The simplicity is that the federal government has a formula that says it shall transfer to every province the same amount of money per person every year for 2 programs. Unfortunately, health and higher education are lumped together. And this is one of the distorting things that follows up our debate because it makes the arithmetic difficult and all those other things. But those 2 programs are to get the same amount of dollars per capita across the country. The way this is done is to, first of all, give every province the right to levy some taxes. In this case, there were income taxes and a little bit of corporate business taxes. You sit in Ottawa and you calculate how much that amount of taxation raises in each province per capita. To use an example, let's say that every province is to get $100 per capita. You take Manitoba's income tax and you say, how much did you raise with your medical income taxes this year? And Mr. Manis, our Minister of Finance, says $60. So Canada says, okay, we'll give you 40 in cash. That's your $100. So you have to first figure out how much the taxes were worth and then make up the difference in cash. That's the fundamental of the system. It grows each year, in theory, by the growth in our economy, again, in very rough terms. And it's per capita, so if your population goes up, you get more money. If your population goes down, you lose some money. And that's the kind of broad outline. Now, what happened from 1985, 86 onward is that the federal government changed the formula in order to make the formula generate less money each year than it would have before the changes. What it, in the simplest terms, is that the federal government has now removed all the growth from the formula, so that no longer does the formula provide more money per person per year to each province. It provides for 5 years, ending in 1994-95, the same dollars per person per year, changed only for population. You still get more money if you get more people, but you get the same amount of dollars per capita. What that in turn means is that all of the increased costs in the system, the normal increases from inflation and the increases in volume that we've all been very concerned about, all have to be carried by the provinces because the federal contribution is not going up. So the capacity of the province to afford those increases from all its other taxes is the problem for all provinces, but particularly poorer provinces. There's a little bit of complexity in how come the federal government's not going to put any money in the system after 1999 or 2000, somewhere in that region. And the answer is, I think it's fairly clear if you think about how your taxes have changed. All of us know that each year we have tended to pay out more income tax because the federal government changed our income tax system so that it was de-indexed, that famous word of de-indexation. So each year we pay a little more income tax even though our income may not have gone up. Well, what that means at the national level is that the income taxes that are for Medicare are generating more money each year. There's more money coming in. And you remember that Mr. Manis, our finance minister, has to tell the federal government how much money his taxes are raising. So if last year they raised $60, the federal government will give you $40 to make up the 100. But if this year they raise 65, the federal government will only give you $35 to make up the 100. So if the taxes keep raising more money and the formula says you don't get any more money, the cash slowly disappears to zero. Now, it would have gone to zero anyway at some point way in the middle of the next century. But with these changes, it's going to zero very quickly in Quebec in 1996.
Because Quebec got a much higher percentage out of the tax take in the first place.
Yeah.
Thank you.
But I don't want to get, the arithmetic of that is
complicated stuff.
pretty arcane, and I don't think it...
The second part of the question?
Well, the second part of the question is Bill C-20, I think. Is that what you're asking?
The question really was, does it interfere with the ability of the province to manage its own affairs?
No, let's have some
Okay.
other...
This is very much a question in terms of how you interpret it. The system that was very well explained just now was a replacement of the older system. The older system was designated money. It was dollar for dollar matching. If you spent $1 on the appropriate thing, we'd match it with a little bit of give and take to try and give more money to the poorer provinces and less money to the richer provinces. But in general, it was a $1 for dollar matching. The provinces didn't like it because what it said is if you wanted to use home care, you didn't get the matching money, and if you did it by physicians in a hospital, you did get the matching money, and the steering effects were getting silly. The federal government didn't like it because it wasn't predictable. They didn't know how many dollars that they'd have to shell out. So the thing got shifted to this formula that was described in 1977. What happened at that point is the province had virtually full control over how it decided it was going to handle its medical spending. And if it decided it was better off doing assistive housing for someone who was disabled and giving them a wheelchair-accessible place to live and an attendant rather than building some sort of an institution, they were free to do it. They wouldn't have been free to do it under the old system. So from the point of view of trying to reorient the system, this was a very good move. It gave them a lot of freedom to do it. But there was inertia. We already had the professionals. We already had the institutions. So trying to shift around when you already have a big infrastructure in place is tough. It's like trying to steer the Queen Mary. So, you know, you don't turn it around on a dime. It turns around very slowly. So from one point of view, the province has had far more freedom in what it does since this change in 1977. On the other hand, the province doesn't have as much money. Now, the social programs, Canada Assistance Plan, those are still on the old formula. Those are still the dollar for dollar type of things. And a lot of the social programs that help people be supported in their home, those are means tested. And those run on the old type of dollar for dollar matching that used to be the case for medical care and for hospital care. It's actually 3 programs plus post-secondary that are lumped in there. So from that point of view, from one point of view, you say the provinces are not being interfered with at all. They have really carte blanche who they want to have deliver services, how they want them delivered, what they're going to be. On the other hand, if you're handed, if you inherit a large mansion from your aunt and you're told you have total freedom what you're going to do, but you don't have all that much freedom if you still got to heat and maintain the mansion. So the provinces are complaining about the fact that if they've got less money, how are they going to keep the mansion up? And I think that's really what the debate's about.
Well, I think the other point was that really what we started this discussion with is the fact that the federal government since 1984 has had, as a condition for receiving the cash portion of the transfer, the provinces had to maintain the 5 pillars of our healthcare system, the 5 underlying principles on which it's founded. So in that sense, there was some interference because, if, for instance, if you didn't have universality of access, then the federal government said, we won't give you our cash transfer. If you have user charges for physician and hospital services, we will not give you, well, we will deduct from the cash transfer the amount that you charge, that patients have to pay. So in that sense, there is, you might interpret interference to say it places some limits on the programs provided by the provinces. And some of the concern we were discussing earlier is that as this cash transfer decreases, the leverage the federal government has to say you must maintain these 5 principles goes away, because now they say you have to maintain the 5 principles, and the province says, fine, you're not giving us any money, any cash transfer anymore, we will do what we want. So, I mean, there's that sense in which there's still some people would say interference.
And I think one of the reasons for a process like this is that the people who will force them to maintain the 5 pillars is the public and the community. And to the extent that the public and community think that these are principles that are worth maintaining, they have to make it very difficult for government not to maintain it.
Jerry, I'm sure that you would have some comments to make about vested interests of various groups to maintain the status quo in healthcare these days.
Yeah, I'd like to pick up a bit on what Reza was saying, in that I think there's no question that there are, they have a real incentive, and they're motivated in part by this notion that healthcare expenditures are healthcare incomes, and to redistribute where we spend our monies in healthcare means to take money away from some groups and put it into others. And as any group, nobody wants to see resources taken away from their activities. But I'd like to just say that I think there's another, probably almost as important element, and that has to do with many of these groups are professionals. They've worked quite autonomously for their professional lives. And so there's some issues around power and issues around who gets to make different kinds of decisions within the healthcare system. And if, for instance, you take money away, resources away from hospitals into community cares, well, you've shifted who the relative level of power, in some sense, between those two groups. And I don't mean power in a bad way, but just who gets to make decisions about how those resources are allocated changes from hospital administrators and professionals in hospitals to community provided care. And so I think it's a combination of some of the traditional financial considerations, which loom high, but also this question of shifting responsibilities and decision-making power amongst different groups in the system. And we all resist having someone take away the power to decide how decisions are made and what decisions are made.
And the powerful areas, particularly hospitals, are also heavily unionized. So you also have the question in terms of trade union and various rules about where things should be. They have managed to get the salary levels up to where they'd like them to be. They're obviously going to resist having an erosion of high-paid jobs. When I was down in the States, they have a horrible problem now that healthcare is eating up more than 12% of their GNP. It's interfering with productivity. It's interfering with everything else. And yet they've started arguing that it's an engine of economic growth and we can't control healthcare costs because it's one of the things engineering the growth of the economy and high-priced jobs. So
I think also, though, we also should maybe say that that's maybe also one of the reasons why provinces are starting to talk about regionalizing and geographic planning basis. And that's a very common approach in Europe, to have some geographic turf on which you allocate health costs rather than an institution versus a non-specific community. So we're going to see more and more experiments trying to push the administration in a different pattern so that that reallocation decision maybe isn't made by the Minister of Health, but is made by some more local folks where there's going to be the political heat, because the minister sure doesn't want that political heat coming all the time at the provincial level.
Although it's important to note that when you move things down to a regional level, power has not moved away from those powerful groups. In fact, those groups are often more apt to be able to hang on to the power and resources when decisions are made locally.
I didn't say it was going to work.
I think we need to go.
I think there's an important point, though, that corollary to your discussion of regionalizing the planning and to some degree the way funds are allocated. It's very important. I think you're right, Ray, that very often the professional groups still maintain the decision-making power even at the local level. But one thing that...
Especially at the local
okay, especially, okay. The one thing that can happen, though, is you can break the link of funding from institutions, so that currently in our systems, the only way that you can get hospital resources is to have a hospital in your community. The only way to have physician resources is to have a physician who provides care. Under these new funding arrangements, and there are many different variants, but the fundamental principle is to say we will allocate a given budget to a region, could be geographically defined, and then that community gets to decide how that is spent within certain parameters defined, of course, by the healthcare system. But the point is a community, even if they didn't have physicians, would get resources which they can then use to try and attract physician services. And so I think there's a very important break in the principle upon which we are funding our system. It's a principle by which we're saying we are funding people and populations who presumably need care versus funneling all of the funds through the institutions and providers. There's a very, very big difference.
Please stop the tape now. This is the end of the video segment for the second workshop. In the video segment for the second workshop, we heard our panelists discuss the state of healthcare in Canada, including such questions as, is there a crisis in Canadian healthcare? How does our healthcare system currently work? And what about vested interests of groups in the healthcare industry? We rejoin them as they discuss the process of reform which has begun to change the shape of our healthcare system, including the importance of public input into this process, and the need for such input to reflect what values we want the reforms to be shaped by.
And I think what's been important is there's been an underlying value in the Canadian system, and I can speak about particularly having come from the U.S., in which we say every Canadian should have, as far as we can go, the same access to healthcare services, and hopefully then health, although we know that isn't entirely true, but regardless of your socioeconomic group, where you live, etc. And the federal government has been able to try to enforce that basic principle through these 5 pillars we've discussed. And I think with the federal government stepping out of that role, as Tim described, some provinces are clearly, they're wealthier. And do we want to start seeing systems whereby residents of Ontario have access to many more services than residents of New Brunswick or PEI? And so I think there's a fundamental question of values underlying this, and that what do we, as Canadians, envision we want from our healthcare system? And I think the federal government has played a very important role in maintaining those standards and in institutionally carrying out the values held within the population. And so that's a sense in which I think the federal continuing involvement is quite important.
Good, and we want to continue that dialogue. We'll go back to the audience for another question, please.
Well, I want to pursue the question of what gets paid for and how the public is involved in those decisions. Tim's opening story made the case for Medicare on the grounds of not having to live in fear of severe economic hardship. And I'm sure most of us, certain kinds of illnesses then popped into mind that would be covered by that, and perhaps cosmetic surgery wouldn't be. So on the one hand, there's a range of services that we will make decisions about. The references will be made to de-insuring certain things. References have been made to hard questions like whether quality of life or medical benefits can be taken into account when age and handicap are involved. The other term that has been used is medically necessary services. And as a lay member of the public, I seem to be an observer of a system where on the one hand, most decisions are made on the grounds of medical necessity or something which are highly technical. And on the other hand, allocation decisions seem to be made by capping funds, which some backroom negotiations between politicians and economists come up with a capping. And I guess I know that ultimately we want to get onto the questions of the rights involved and how that's affected by age and handicapped and that kind of thing. But I think we need help locating the issue. I mean, are we talking about rationing? Do we need to open up the notion of medically necessary decision? Is that something that should be opened up more to public involvement? So I'm focusing your attention back to the kind of getting our language straight and helping frame the question to get on with the question of how we decide what gets paid for.
Jerry, I'm going to ask you to respond to that first.
Okay. I guess my first answer is we are rationing. We have been for years. What we need to discuss is how are we going to make decisions about how those, two things. How do we come to decisions about how we decide how to ration? And secondly, what kinds of rationing, what criteria and principles underlie the rationing? So that thus far, at least in principle, we've said we want to try and ration who gets care based on ability to benefit, based on need for that medical care.
And desire for it.
That's right, and desire. If you have to show up to the healthcare system. Things like user charges start to ration on the basis of ability to pay, because now you have to be able to pay in order to get that service. So there's some very different principles by which you can think about access to services. Secondly, I think this question of medical necessity is probably one of the key questions we're going to be facing in the coming years. In that, for the last 20 years, we've been able to be fairly loose about how we define medical necessity, who gets to define it. Largely, we've let physicians define that term within broad limits. And for years, we've already said elective cosmetic surgery is not going to be covered under a public plan because that clearly isn't medically necessary. It's just to make you look better.
Unless you've got severe birth defects or severe accident.
That's right. If you have a medical, if it's a medical problem, or for instance it's coming out of an accident, then a physician, if it's deemed medically necessary, the system would pay for that care because it was no longer seen as elective. Okay? I think we're going to be facing these kinds of distinctions, these kinds of choices more and more in the future. And I think the fundamental fact is that we have the capability, we will always have the capability of probably doing more than we can afford to pay for as a society. So we will always be coming up against the edge of how do we make these decisions. And so I think the role of the public is crucial in here, because what that means is we can no longer say, oh, we will only provide those things medically necessary and those things not medically necessary we won't provide, and that's the Knight's break line, because that's a very clean one. The problem is, what we're going to say is, we can't even provide everything that's medically necessary, and some might say medically necessary, and by that I mean the patient would benefit. The public has a crucial role, because fundamentally we're coming up against value judgments. Who are the groups in society who we want to make sure have services? Under what conditions, for what types of medical conditions do we want them to receive services? These are fundamental questions which I can't answer, Reza can't answer, a physician can't answer. So one of the things we have to sort out is what are going to be the roles of different people in the system vis-a-vis the public, and how do we try to get them to interact? Because historically what's happened is whenever you brought professionals and the public together, the public was at such a disadvantage that they usually were overshadowed. It's also very easy to turn these into technical questions and everybody say, oh, this isn't a question of values any longer. This is a technical question which only a professional can decide. And I think we have to be very careful to guard against that kind of co-opting. We're talking about fundamental questions of value.
But there's also the question of whose values.
Mm-hmm.
Are we talking, if we're talking the public's value, are we talking the public as citizen or the public as consumer or patient?
Mm-hmm.
Because one of the things that's been well found out is that the value affixed on certain life statuses is very different by people who have to live in that status than by people doing it hypothetically who don't. Mm-hmm. There's a lot of things that if you're not walking in that person's shoes, it may not seem as bearable or as critical. And there can be a real problem. One of the reasons I really object to the Oregon procedure is that people were making decisions that they would not have to live by, because they knew that they would have better quality insurance, and this was coverage they would have, and they were deciding what was important for other people. I had a real problem with that. There's an empirical question, and I don't know the answer to it. is if we really went down and scrutinized care in terms of whether it was necessary and whether the patient wanted it, whether we would still find it necessary to ration things that were necessary and wanted or beneficial and wanted after we finished with that procedure. I don't know. It's an empirical question. I have a strong moral view that you have to start with there, that it is immoral to say that we're going to have to deprive people of beneficial therapy that they would like in order to maintain 2 hospitals in a community that only needs 1, in order to make sure that a particular surgeon is paid $500,000 a year, in order to make sure that unionized employees are all keeping high-paid jobs, in order to make sure. To me, that's very problematic. I would first want to make sure and see, are we using the resources as efficiently as we can, and then if we really can't afford it, we'll come back. But it's so hypnotic. It's so much fun to play these lifeboat games, you know. Here's 5 people who needs transplants. Who should be allowed to live? Whose life is worth living? And I get really queasy at those sorts of questions. I'm not convinced we have to do it yet.
Oh, I think we are doing it and will have to do it, because medically necessary is not in any sense an absolute. Medically necessary is a rolling quantity that has to do with social norms, and it has to do with technical capacity. And in a developed society, there is virtually no end to the technological capacity growth that is possible. The question is it ethically, morally desirable, and how do we deal with that? There is no fixed medically necessary criteria. We now deem medically necessary things that were not medically possible 10 years ago.
I was wondering if the panelists could shed some light on what the process of reform looks like, given that we're in and moving along the process of reform of the healthcare system. Like, how long do you think it takes or would take for this reform that we're looking at now to take place? What would be a good process to get us there, and how can the public be involved? How could I be involved in helping that happen in a better way?
That's a terrific
That's a small question.
But I think the thing that I'd want to stress is that don't think of it as a reform, because a reform implies there's one magic model which is going to work everywhere, and I don't think that's likely. I think what we need is, let 1,000 flowers bloom. We need a lot of sensitivity. We need to try out models. Nobody knows. I think if any of us sat up here and said, this is the way that a system is going to work, we'd be fooling ourselves or you or both. People don't know precisely how it is, and there's a lot of really good things about the system we have now that we don't want to lose. So that we have to be careful when we're reforming, that we don't lose track of people who happen to be ill, we don't lose track of people who happen to need care by saying, oh gee, but if you came back 5 years from now, we'd have such a wonderful system in place for you, and would you please manage to wait for 5? I mean, people need care now, and we have to make sure that we're doing it. So I think in terms of what the public has to do, a lot of it's going to depend on public values and what public thinks are important. Priority setting comes down, in a lot of cases, to the public values and what they think are important. I think it's crucial to have the public there as a counterweight to some very strong vested interests, because one of the things that has always worried me about the talk about priority setting as being through public forums or any of these other things is the people who come to those sorts of forums come because they have a strong interest in that area. And they usually have a strong interest in that area either because they provide the services or because they consume an awful lot of those services. But in neither event are they the general public. Oregon went through an elaborate process to try to decide what should be paid for people who are poor. They went to all kinds of efforts to bring in the public. 85% of the people who came to those forums were high-income, educated health professionals, almost exclusively white. That you really have to be nervous if you talk about the public, that what you're not going to find is something that gets hijacked for special interests who are going to benefit from a certain set of services. So I'd say one of the things involved is to understand what the issues are, what's important, what you want to make sure gets preserved, what things you think should be changed. to make sure that the people who are responsible for making those decisions know it, and for making sure that certain more vested, specialized interests, you don't find as steering to the ones who can yell the loudest or be the squeakiest wheels. And I think the whole Canadian constitutional process is an awful example of what happens when what supposedly public consultation ends up just to be listening to whoever's loudest.
I think one of the things I would say is that we need to realize that an enormous amount of stuff is already going on. We have changed the way we deliver all sorts of services and barely noticed it. Just a couple of examples. We do so much more day surgery now than we ever did before for all kinds of, partly because of technology, partly because of technique, and partly because we've just gotten comfortable with the idea that you can do this. So all those things have contributed. Mums now go home very often in Canada, 24 hours after delivering a healthy child with no complications. And we know from good studies that that's actually healthier than staying for a few extra days, because the risk of catching something in hospitals, kind of like the risk of catching something in a daycare center, you know, it's pretty high. So we're doing a lot of things already. At the same time, there's the very fundamental underlying things that are awfully hard to tackle. And I guess if I were saying, what do we need to do? I think we need to do what the United Church is trying to help happen. That is to get folks who deeply care about their health and their communities able to kind of let go of some of the myths and begin to trust their own ability to think through these questions logically and in a value framework, and to have a stake in that process, so that we don't hysterically shoot every health minister that closes a bed, which is kind of the approach the press takes, and the approach that people are kind of encouraged to take, that any change in the current system is an erosion. Well, it's not. There are some changes going on that are very positive, but some of the really hard ones haven't much begun yet. And what we're trying to do here, I think, is a vital, vital part of the process.